apparently don't function well with the telephone or the computer tonight. But it's a pleasure to be here, and in particular, it's a pleasure to introduce our presenters, our guest presenters. And I've had the privilege of knowing Elizabeth, or Beth, as most of us like to call her, for a number of years, and we've worked in different capacities in our community. But most recently, I've learned about Beth and Tony's story in terms of the journey they've gone under, or their process, or navigating the healthcare system through Tony's double lung transplant. And when I had a chance to, I've been following Beth, and I've been following her blog and her posts on Facebook, and I was, just couldn't believe the story. And when this opportunity came up to invite someone to come and talk about navigating the healthcare system, she was the first person I thought of. And then when I sat down with her and Tony and heard their story and what they're doing to help other family caregivers in the community right now going through a similar process, it just, I was gobsmacked. So it is such a pleasure to have Beth on the call tonight, and just based on the conversation we have, she's an incredible asset for other family caregivers and quite frankly to health professionals. So obviously she didn't start out as a family caregiver. She's got a background that includes the biotech sector. She does a lot of focus on high school students and helping them garner movement forward in gathering careers and how to present themselves and brand themselves. She obviously, her life changed dramatically when her husband went through a double lung transplant, and that was just getting there, not to mention during the surgery and post-surgery. So she describes herself as this extreme triple shifter, which I think is such a great description in terms of someone who is not only working as a career-driven woman, but she's a wife, she's a caregiver, and she's well beyond that as well. So she's pulling many shifts throughout the day. And even though Tony's health is continuing, and she's certainly back in the workplace, the role of a caregiver and the activities a caregiver does certainly might change, but she is and will be a caregiver. So what I'd like to do is certainly invite you to take a look to learn more about their blog and their journey as well. And we've put up the information that if you hashtag Transplant Rogues, you can do that. You're well ahead of my level of technology capacity, but they do have a blog as well, and I certainly encourage you to visit her site as well, especially obviously if you've been a transplant survivor or a caregiver. So welcome, Beth. We're truly honored, and we really thank you for your time tonight.
Thank you, Wendy and Janet.
Yay. And I'll just, at this moment, just introduce Jody. And so we'll just go to our next slide. So Jody is another wonderful person that I had the chance, and Jan and I had the chance to connect with most recently in the last couple of months. She's providing some services to family caregivers in British Columbia as a consultant. But most notably, Jody is a social worker, and I've learned a bit about her, the work that she's doing with the Calgary Family Caregiver Support Society. She's also an instructor with Vancouver Island University in some more integrative body psychotherapy work. And one of the areas that really impressed me about Jody was looking at how caregivers build not only capacity but their support networks. And as we know with family caregiving, we're at risk if we try and do it alone. And Jody has some really great ideas around harnessing those networks, being able to speak to other professionals involved in care, and also the whole aspect of self-care. So she brings a wide variety of experience over 20 years in crisis intervention, problem solving, support, keeping ourselves mentally healthy, as well as bringing communities together in a wide variety of different roles and programs. So again, we are so excited to have Jody on the line and contributing as our healthcare professional. And we're really looking forward to hearing more about their stories and their case studies. So what we'd like to do is we'd like to give Beth an opportunity to talk a bit about her story. and in terms of it from a family caregiving perspective and in terms of a healthcare navigation perspective. So in a moment, we're going to turn the mic over to Beth and have her share her story. And then what Janet and I are going to do is we're going to facilitate some conversation and some dialogue and some questions. What we would certainly encourage you to do as listeners and our participants, there's two primary ways that you can participate or ask questions. The first one is to ask your question in the chat box, and we'll be monitoring that chat box. So if something comes up or a question or you want to add something, please use the chat box. And the second way that you can do that is by raising your hand in the top bar of I'm pointing to my screen, you can't see that. In the top bar of your screen, you'll see a little person with their hand up like this. And you want to click on that, and a little pop-up screen will say, Wendy has raised her hand. And then either Janet or myself will invite you to ask a question. So again, you don't need to participate. You can certainly listen and absorb. We certainly hope that you will. We think we have this incredible collective whole of caregivers and professionals that can really lend to this important conversation about navigating the healthcare system. And we have two great presenters with their own personal stories and healthcare professional stories to really bring this issue to light and to be able to explore it and discuss it. So without further ado, and I can stop talking, I'm going to pass it over to Beth. So welcome, Beth, and why don't we say about 5 minutes for you to share your story. That'd be great.
Okay. Thank you, Wendy, and hello to everyone. We talk about doing extreme caregiving. I'm sitting in the, what do you call this, the lounge on the third floor of the Easter Seal House in Vancouver, because today we are traveling because Tony, we can't do in and out of Vancouver from Vancouver Island in a day because of Tony's health. So I guess our story on the slide, if they move the slide ahead, Tony's surgery was in May of this year, and it had taken us a bit of a road to get to that date in May. You don't just go onto the transplant list. You first have to be identified as a candidate for transplant, which means you're pretty sick. Transplant is the last stage of the game. So people who are going into transplant have to have no other medical input options. And Tony actually was trying to be proactive about getting his name onto the transplant list, and it took him about 3 to 5 years broaching the subject with doctors, many of whom, well, not many of whom, it was 2 or 3 doctors. One GP actually sniffed at him and told him he would never get a transplant, and that was about 5 years ago. And at that time, we did not know what the criteria for transplant were, and that was one of the things we've since learned about where to find that kind of information. So once you get referred to the transplant team, it took us about 6 months between referral and the time we got into the BC Transplant Team office because they were a bit backed up. They are really growing by leaps and bounds at BC Transplant, and the teams are doing more and more surgeries. And so I guess I like to say they're victims of their own success. There's so many people now being referred and transplants being done. So once we landed in front of the transplant team, you go through a process called PreAssessment, and that took us 6 months. They do a whole lot of tests, a lot of scans, bone density, angiograms, all kinds of things. They need to know what they're dealing with when they go in to do a transplant. And so it takes a lot of time up front to pass through the test. And then we were on the waiting list. And we were really fortunate in that our wait was only 3 months. But while you're in that phase, every day seems like a long time. And then in May, Tony, with the phone rang, and there's a whole funny story about that, but we got to the hospital and the transplant was a go. So since May, he was in the hospital for 2 weeks. They like to get you, like any surgery, up and moving quickly, and he was in really good shape, and off we went to, we had to live in Vancouver close to the hospital for 3 to 4 to 6 months. we were there for 4. And in that time, he had a couple of complications, not to do with the lungs themselves or rejection, but with bone healing in the sternum and things. So he had a few setbacks, which we're learning is the name of the game. So I don't know what else to say. It's ongoing. Transplant isn't a cure. You're trading one chronic disease that's fatal for another chronic disease called transplant disease that is more manageable, but comes with its own risk. So we're now playing a game of balancing rejection and taking anti-rejection meds, but not too many so you catch an infection. And anyway, so the caregiving role, as Wendy says, will continue on, and it does wax and wane. Last week we were in Vancouver for, or 2 weeks ago we were here for 1 half-day clinic appointment, and Tony had pneumonia, and we were here for a week while he was in the hospital. So these things just pop out of the blue once you've had a transplant. So it is an ongoing process. And I'd just like to say one last thing, this last one, the last bullet point, keeping myself sane and healthy. Some days you wouldn't know that. So, yeah. It is definitely a journey.
Mm-hmm. Right. Well, thanks for sharing that, Beth.
You're welcome.
I'm just going to do that. I'm not taking any risks. So I'm already contributing to the demise of this webinar at the start. So what we wanted, we had a couple of questions to ask Beth at the start. When I had first engaged her, I was really quite interested to know from her perspective what were the most challenging parts of navigating the healthcare system. And we'll ask the other 2 questions, but I'd like to start with that. So asking Beth, for you as a family caregiver, and don't be afraid to talk about Tony as a patient experience either. Our focal point is family caregiver. But what's really important is that this is patient and family caregiver, and your idea of being a team is really important. So that would be great if you could start there for us.
Okay. I think the most challenging part for me of navigating the health system was coming to terms with the fact that it's very siloed. So what that means is you can get nice service and great health care when you have 1 or 2 doctors. But once you get into a more complex system and you're needing help from a whole variety of different sources or agencies, things become a whole lot more difficult. So even for Tony, getting that referral at the beginning was difficult because BC Transplant has its own criteria for referral, and they don't communicate as effectively with GPs as maybe could be happening. So it wasn't only us who didn't know what the criteria for referral was. The GPs were unfamiliar with it. And I think every time we've run up into a problem, it's been because one section of the system doesn't know what the other section is doing or hasn't kept up. We had some issue getting home oxygen, and we've since found out there are a lot of other people in our boat where the program that determines whether or not you qualify is using guidelines that a lot of people have difficulty with and can't fall into things. So again, it was, I don't know, a lack of communication about the realities of lung disease or what was going on, but those were where our barriers were, I would say. It was learning how to get around things. And when you were introducing Jody, you had said how important it was to build caregivers' capacity and also to build caregivers' networks. And I think for us, the way we got around this siloed nature of the system was that we early on had to start identifying who was on our team and what it was they were doing, so that instead of trying to handle the problem ourselves, we would go to the appropriate person on our team for either advice, or they would pick up the issue and run with it and work on our behalf to get the problem solved.
Mm-hmm, mm-hmm. And so would you say in that regard, one of the most important pieces around that is it's great to be able to identify people on your team. Is it also really important to know what that person's scope of abilities are in terms of how they can actually help you, and sort of that language between the two of you in terms of your ask?
Yeah, I think so. And at first, that was one of the places where we tripped up was, you know, sometimes I was just phoning people out of the blue, and, you know, with the home oxygen issue, I was crying and phoned our doctor and talked to one of the people in the front office. I don't know what to do. Ah. She's like, don't worry, we've dealt with these people. So, you know, like I was saying to you, sometimes it wasn't the best Dale Carnegie type moment where you didn't have all of your, you know, faculties about you. You're just reaching out to wherever. But as you go along, you do tend to pick up and learn who's who in the zoo kind of thing. So definitely I would say for caregivers starting out, knowing who is to do what and who can help you in what capacity would be helpful information.
Mm-hmm. Yeah, that's a great tip. I'm also curious too. I mean, I think about the workbook that you're developing or in the process is, and Jody, I know we're going to get to you, but feel free to jump in at any time. But what I was also going to say too is I know sometimes when it does get complicated, and Beth, you talked about this, is this incredible importance of kind of documenting those interactions and you know, kind of the name of the person, what they can do, who they are, if there's any follow-up action. Because what I've heard from our conversations is that as a family caregiver, you really become the quarterback of the system in terms of you're the one that's still connecting all the dots and all the players and making sure that the follow-up is being done. Would you say that's an important part and a good strategy?
Yeah, absolutely. I think you feel like you become the case manager because you're the one who knows, and that's a good point to document things. And we eventually developed a worksheet for doing that. But who did you talk to? Who does what? And balancing things off too. There were scheduling issues that we often had between different specialties. And you had to manage, you know, this appointment needs to come after that appointment or before this, or we need to do this before we do that. And just being, like you said, I guess caregiver, not caregiver, quarterback was a good analogy.
Mm-hmm. So, and sorry, Jody, as I said, if you want to jump in, just cut me off. I kind of want to pick up on that, on the piece, though, that, you know, you just mentioned about sequencing and about kind of clarification too. And one of the questions I had, and again, you know, Beth, the point that you've made, it comes up in one of the slides later, is that the people in the system are really working as best as they can for patients and family caregivers, and I think that's really important. It's the overall system where we have a lot of those challenges. And do you have any particular tips, say, around, or did you have any difficulty in making sure that when you had questions or when you were unclear, did you feel that you got the time that you needed to make sure you understood that sequencing and that you really understood what you had to do as a family caregiver and patient?
Yeah, as soon as we got in touch with or landed at BC Transplant and got referred into that program, things got better really quickly because they have a team system. So when you land in Transplant, you get, there's a program coordinator who's a nurse, and she was invaluable when I was struggling. We had some issues with scheduling of appointments through our local hospital, which isn't part of the health authority. That was another issue with things being siloed, is that BC Transplant is provincial. The health regions are health regions, and our local hospitals run by the Catholic Church. So we had difficulty getting some of the tests done in sequence, and our transplant coordinator was helpful in providing me with information on how the system functions and who I needed to call next to help expedite some tests and get things in order.
That sounds like a valuable resource, yeah.
Certainly having a team, like there's that nurse transplant coordinator, there's a psychologist, there's a social worker, and those people together look after the fact that you have to be housed for 4 months as the caregiver away from home. They're there for the psych component of things, to talk to you if you need to sit and talk. Those supports are there, but they weren't there for us until we hit the transplant team, and that referral came through for us.
And so, I mean, that's quite interesting. I mean, I suppose in a way it's, you don't cross that bridge until you cross that bridge, but from your perspective, you hope, like there's hope that you're going to get a transplant, and so you'd want to plan for that care ahead of time, I would think. So that must be a pretty challenging spot. Not, you're in this pre-phase, so the pre-phase, you can't really do anything about it until you actually are successfully on that, you pass the pre-assessment. That I think for most family caregivers and patients, that would be challenging because your life sort of comes at a standstill. How can you make decisions about work or how much to work or even just general life things when you're not sure where you're going to live for 4 months in Vancouver?
Yeah, I think that was a big stress for us, especially when you listen to the news and you hear Vancouver is the most expensive place on the planet and the vacancy is non-existent and you'll never find a place you can afford. But what we learned was that the social workers know all of the landlords, within the small radius of the hospital, and that's their job, is to be assisting families with this sort of thing. And so they have all the ins. So there are a lot of places that have short-term stays and cater to families and hospital patients that you don't realize until you land there and they tell you, don't panic, we can help. Yeah.
So, I mean, it really sounds, we're going to get into kind of the next question here about what were the best tools in your toolbox, but I mean, I think about this a little bit, and I know this might be a strange way to think about it, but I think the importance in a way of kind of networking, for lack of a better word, like in a way, when we go out or whatever work we're doing, whether it's collaboration work in the nonprofit sector or whether we're a sales representative in our in our life work or we're HR consultants, one of the things that we do is we connect with people and we understand how they can help us and how we can help them. And what their role is, and kind of thinking around that. And in a way, that's a very good tool to have as a family caregiver in terms of saying, okay, well, this is a problem or this is a challenge, and we don't know where to go next. And so I'm going to start putting my feelers out in different areas, and maybe that's in my own community, or maybe that's specifically with this team of professionals. And it sounds like, when you made those right key connections or those you've networked with the right person, that all of a sudden things started moving forward. And I think what that shows is that and correct me if I'm wrong, but as family caregivers and even healthcare professionals, that we need to become these educated consumers of our healthcare system, and that means using skill sets like being able to do cold calls and network to try and find the right information and the right people. Yeah,
certainly. Back to the example of, fighting to get coverage for Tony to have oxygen at home. I heard no and didn't take no for an answer and felt like I was talking to a brick wall with this one particular office. So, I just went on to Google and the government website and found out who was the boss of that particular program and phoned them. And, once the boss got looped in, you started getting callbacks from the, program one lower down. Yeah, also as far as networking goes, it can be very isolating to be a caregiver as well. So, at first what I was doing was I turned my Facebook feed into an information channel. So I found there are a number of transplant chat groups on Facebook with people who are transplant survivors, and they're there to chat with each other if someone's down, if someone's having a medication reaction. A lot of answers are phone your team, phone your team. But they're there to answer questions. One of the people we connected with quite early on was actually a 14-year-old girl with CF who had had her transplant just about the same time Tony got on into pre-transplant assessment. And so we started following her on Facebook, and she had photos of what the surgery was, how long it took after your surgery, what it's going to look like in the hospital, what tests they're doing, that sort of thing. So I would say for caregivers too, don't discount social media. Make sure that you're on to Facebook or wherever, and there's caregiver pages, there are caregiver groups, the Canadian Institute for Health Information is online, and they're always putting information out. I connected up with BC Transplant and Lung Association pages, just so you're always getting an idea of what's going on, and you feel like you're keeping up.
Well, one of the interesting things I had noted, I think Beth and I, we have different touch points in our community, but for me, what was really interesting is I from both ways. When I would look at your Facebook page, I'd see how much love and support was coming from your community when you were in Vancouver, when you felt those challenging times. And so just from an interesting perspective from your friends and family who couldn't physically be there, that we did use social media as a way to support you, as a way for you to raise money, to help with the process, but also to update family and friends. And that was one thing I was really, impressed by is, how you did use that component. I mean, obviously you use other components. You're an incredibly one-to-one person, and the support in person was important. But that whole online piece was something that seemed very valuable to you in terms of one of the tools that worked for you in your toolbox.
Oh yeah, I would say that absolutely, and it allows you to communicate with many people at one time. So when you're rushed and freaked out, and here's a picture of us having our lattes, we're fine, it's okay. That was, I think, helpful, so you could get the word out to a lot of people. And it was, I think, Tony, I was very touched by the amount of people commenting, because you've got friends on Facebook that you don't always hear from, and then they pop out every once in a while. And Tony was really overwhelmed when he saw all of the people commenting, because he's somebody who's really quite quiet, and he's been ill for so long that, like, how do people even know me? Like, who are these people? Because he's not really been out for a couple of years. So, yeah, that was helpful for him as well.
Yeah. No, those are great points. I think, when you've talked a bit about this too, in terms of, the fact that caregiving is a marathon, and that navigating the system is tiresome and frustrating. And one of the things that I heard you, connect on, quite early on is that, taking no is not an answer. And I think this is really an important point, I believe, is that as family caregivers, we actually, as patients, Tony knows himself best, and you know Tony best. And the person that sees him for 15 or 20 minutes is just seeing a snapshot. And so taking that no for an answer is actually such an important piece, because, we know ourselves best. We know our family, the person that we're caring for best. Right. And so I think that's a really important point that you've made around that point.
Yeah. Well, and I think, too, a lot of times, you know, if our GP, with whom we've got a really good relationship, and he goes to bat for us, he explains things to us, you know, so we have a good relationship with him. If he said something and we didn't like it, we would accept it. But, you know, when we're working with another new section of the government or some sort of organization, and it's about supports and, you know, you have to do this, it's like, really, do we? Or is this just, you think you know? Because we ran into, with social services, there was some support there, and I filled in the forms and I sent them the 55 pages of our financials. I faxed that in. Took me a few days to pull that together. It was just insane. And I was still hearing back that, no, this program doesn't exist. And our transplant social worker said, it absolutely exists. I just had someone get it the other day. So even sometimes within a government department, they don't know what it is they do. Like the woman that was doing our case was the kindest, most helpful person. And I felt badly if she'd gotten in trouble at some point, because this had to go up and down ladders and across laterally to different departments. And she was legitimately trying to help, but she had no knowledge that this support piece was in place and that it was offered by her own ministry. So, you know, sometimes within the government department, just because you hear no doesn't mean that's the way it is. You know, I always joke that it's like the Revenue Canada help line when you're doing your taxes. If you don't like the answer they give you, phone back, because a different person will give you a different answer.
Right. That's actually a good tax tip for us too.
Yeah. Yeah. Good tax tip.
So I just want to draw the attention to the chat box, and Pastor, thank you for sharing that, Pastor Mary Moon. If you can hold on to that question for 1 second, I think this might be a really great question for Jody. So if you can just hold on just for a few minutes, what I'm going to do is just open up the line for any questions for Beth. And again, you can do that through the chat box, or you can raise your hand and ask a question. But Pastor, we're going to get to your question. It's a really great question. Thank you for bringing it to our attention. So any questions for Beth?
I'll ask a question. It's Jody. I'm wondering, Beth, like, you obviously, you know, you call yourself a rogue caregiver, and I think that's really clear because you obviously have taken so much on and had to really, you know, have a whole other element to your personality in order to be able to do this, you know. So I guess my question is, you know, for someone who's beginning their caregiving journey, what kind of advice would you give yourself, you know, then that you know now, kind of thing?
I think the biggest piece for me that even I, you know, it struggled for me was understanding early enough on that I was a caregiver. And I didn't identify as a caregiver because I'm Tony's wife and we're a team. And I think even without, you know, being hardcore and going on Google and phoning the boss of that guy, making sure that you're documenting everything. So, you know, we had really messy notes, and then, you know, I designed this form. I didn't. I copied it off of what the doctors are using in the clinic. Just a way to keep notes so that you've got the date, here's the issue, here's what we discussed, here's the resolution, and a checkbox, is this complete? And then you've got, you know, a discussion point. And we fill that form in we go every 2 weeks now to clinic, but it's in Tony has a patient binder. Again, copied that idea from the hospital. Everyone's got a binder, not just a file folder. So he's got a section called clinic notes. And if an issue comes up, you know, it's not serious enough to phone the team, but it needs to be dealt with, it goes onto that sheet for the next clinic visit, so that we're not missing out on anything, and you can ask the doctors the next time and make sure it's written down and just clarify with them, you know, before you leave, saying this is what we were discussing, am I right in saying, we need to stop this med, or we need to contact this agency. And then if there's any trouble contacting an agency, say, you just make a note in the next clinic sheet saying, it didn't go well, we're going to need some help. Who do we talk to?
I think that is such a good point. Yeah, it's Jody again. I just loved what you said there, because I often say to caregivers too, it's not like, an alarm goes off or a light starts flashing the moment you cross over from being, a caring partner to being a caregiver, and often at the beginning you go back and forth across that line too. And so I really appreciate that part of the journey of being a caregiver is this idea of just accepting that that's what you are, that it's not a temporary situation. It's going to be like this, and this is kind of the new normal. And of course, you'll still always have, days and hours where you get to just be a partner, but that caregiving piece is now part of the new reality. And just like any change we make in our lives, especially change we don't ask for, the first stage is denial. We don't want to really see it that way.
Absolutely. I was working in a job retraining program at the time with, my two colleagues who have done, worked in group homes and things, so they're familiar with caregiving. And one of them said to me one day, "You're the caregiver, aren't you?" I'm like, no. What does that mean? No. And it's gradual too at first. Well, at least with Tony, because he'd always had lung problems, and his family had lung problems, and he had asthma until the day he came home with 25% lung function. And then it's like, wait a minute, you told me you had asthma. And that's kind of when I stepped in. It's like, I need to be coming to the doctor with you, because you don't go from asthma to 25% lung function. Like, this is nuts. So, I think that was kind of the day. It's like, oh yeah, this is not good.
Beth, thank you for sharing your story. And what I would ask, there's another question coming up, but I will get to that in a second. But what I want to say, Beth, if you have time to stay on the line and jump in, please do. If you do have to go and you have other things to tend to, we completely understand. But thank you. Just thank you for that story and your personal experience and what worked and what didn't work and what you learned. Just amazing. So thank you for being on the call. Please stay on if you can. If you can't, we completely understand. Okay, thank you. We're gonna head over to Jody in a second. I just want to bring up the question, and I might have to get clarification, Helen, from you. But Helen wrote a question as well in the box around. Do the people on your team have to be healthcare professionals, or can lay people advocate for you or get information on your behalf? What I wouldn't mind doing at this point in time is maybe if we can just hear from Jody, and then we can kind of answer 2 or 3 of these questions at a time, if that's okay with everyone. So we'll just go on to Jody. We've got your questions. They're great questions. We're going to get to them. And so we're going to pass the microphone over to Jody, and who's going to talk a bit about kind of a typical client or a common case that'll come through her door or on the phone or in person.
Okay. So like you saw at the beginning, I work for an organization that does caregiver support. So a lot of the people that we see are dealing with dementia in some form or another. And what also happens in the caregivers that we see, or the caregiving families, is that, both people are sort of advancing age. So not only is the person with the issue, experiencing some of the things of aging, but so is the caregiver as well. So often what happens, the caregiver is frustrated, they feel really overwhelmed, and the other thing is, if there's any issues in the marriage or with their kids, adult kids, or financial issues, like any of that stuff, that then you add caregiving on top of that, that can create a pretty complex situation with lots of really complicated feelings. So if already maybe there's some resentments or there's some issues that haven't been dealt with, then you put caregiving on top of that. We know with caregiving there's a lot of guilt involved, there's a lot of exhaustion, and of course that's all mixed in with the love and devotion and care we have for the people that we love. So you see how it gets a little complicated. Then maybe, they've had a situation where getting a diagnosis has been pretty frustrating and time-consuming. So maybe the caregiver's been aware for a long time that something's not right, but it takes a long time for that caregiver to get their perceptions validated by the system. So then what kind of happens is they begin their caregiving journey already in a situation of being disappointed and frustrated. Like they're already frustrated, right? So like Beth said, really eloquently was, it's a huge learning curve to be a caregiver, right? Like right at the beginning, first of all, you have to accept, okay, that's what I am now. But also, you have to learn, there's so many people to meet, there's new people in your life all of a sudden, healthcare professionals, there's this there's Karen from SORT, there's this person from Home and Community Care, and, we know as humans, we learn best when we're calm. That's when we learn best, right? When we're calm, when we're not stressed out. If you wanted to learn something new, you would probably not choose a very stressful moment in your life to do that. But this is what gets married together when we're caregivers, right? We're already stressed, we're frustrated, maybe we've been a little, disappointed already in the services that we're getting. Now we've got to learn a whole bunch of new stuff. So we're not in a great place to do that. And it becomes like maybe a great big ball of yarn, and you can't find the end. You want to unravel it and roll it up properly, but you just can't find the one end to begin. So this is what starts to happen in our experience. And of course, the caregiver often, will contact our organization because they're actually looking for some support. Even respite or that kind of support, which is really not what we do. We're there to support caregivers with information and education and emotional support. But what happens a lot is that caregivers are, they have a higher level of expectation of what's going to be provided for them from the formal services. So they kind of expect sometimes that someone's going to come to their house and do some of the personal care. And depending on the diagnosis, that doesn't happen all the time, right? So then there's another sense of overwhelm of like, wait, I'm going to have to do all this. I'm not going to be able to do all this stuff.
Mm-hmm.
Yeah.
Well, and I think I'm just going to do one quick interjection here, and if any of you have had any conversations with myself or Janet, you've likely, heard us spout out the statistic that at least 75% of all care is done by informal caregivers, family caregivers, and that ranges everything from being that quarterback to case management to transportation to anything to do with household maintenance, meal preparation, personal care, queuing systems for someone with dementia. Dealing with behavioral issues, it's this broad range, and that our formal care, is really only able to provide, as we know, a small amount of that care. And so, I think Jody, you just nailed it in terms of we're dealing with caregivers that are already compromised to start with, and then we're adding another layer of extreme work and this extreme learning curve. And so we're not really setting up our family caregivers for success in that regard. So, so thank you for that. Well, we're going to go on to the next slide, and we've got some of our questions. And, I think you've lined out, in terms of some of the challenging parts of managing the healthcare system already. I think we've really talked about some of those pieces. If you want to add anything to that question, that's fine. I think it would be great from your perspective to hear about what are some of the best strategies that you find, or from other family caregivers' experiences, to successfully navigate that healthcare system, maybe with the lens of dealing with a pretty emotionally and physically tiring disease like dementia. where the progression only becomes more complicated and more work and worse.
Yes, okay. So, and maybe I can sort of, as I go, try to answer the questions as well, because so some of the strategies that we work with and that we think, in our experience tends to work is, for caregivers to have a sense of, so what I've described there is caregivers are looking to the formal system, the formal healthcare system, which is helpful and definitely has resources. And, that's part of what caregiver support will help you to access. But not all of your needs as a caregiver are going to be met by that system. And part of the reason for that is to understand that there are many different kinds of needs that you have now as a caregiver. One of those needs is, for information and care and practical things. But another one of those needs is for emotional support. And, what I like to say is to be seen and heard, like simply to be seen and heard in your experience. To have somebody be able to say, what you're doing is really hard. Wow, you've really experienced a change in your life. And so sometimes the professionals that we're going to see in the healthcare system aren't set up to be able to meet that need, right? So sometimes those needs are best met by people who are not formal healthcare professionals. So sort of like Helen's suggesting, can the people on your team be lay people? Of course. We use in the Cowichan Valley a model called support circles, and when we do that, we try to recreate around the caregiving family a circle of support, and that mostly includes people in their lives, or maybe who were in their lives before this diagnosis. That what tends to happen is that friends and social connections can sometimes fall away, or we tend to withdraw a little bit. So having those informal people in your life, whether that's a neighbor who will come over and stay with the person so that you can go out and go grocery shopping, or a friend that you can go for a walk with and just pour your heart out. So it's kind of knowing that you have a lot of needs that are really important but are not necessarily going to be met by the healthcare system. So it's helpful when you are interacting with healthcare professionals to be able to be concise and kind of know what it is that you need from them, right? So what you need is this kind of information. And so the other thing that I can say is that like Beth was saying, if you keep a dedicated notebook, this helps a lot with that sort of big ball of yarn experience that I was saying, is that the idea that, you can start to make it more clear by writing down the names and titles and roles and contact information of the healthcare professionals that you meet, so you understand what they do. And you can even have a little note next to it, call this person when. So one of the big challenges that we find is in terms of after hours. So that's another piece of like, well, who can you call after 4:30? Okay, so I'm just seeing another question here, that the model requires the family caregiver to ask for help. And what do you say to family caregivers who are resisting help? Yeah, that's a really good question. I think it's like any other form of change. People resist change. And I think that when people are resisting help, that has a lot to do with, acceptance of the role of caregiver, right? And a lot of the time, of course, we really feel that we're going to be able to keep all the balls in the air and we're going to be able to do it. And we really often, as caregivers, feel so protective of our person who has begun to, say, lose some functioning. In the case of dementia, they've begun to act in a way that we know that if others outside of our family could see them acting in that way, that person would have feelings about that. Now, whether or not they have feelings about it now is, sometimes they don't. But the person that we loved would not want to be seen in that way. So what happens is there's a deep protectiveness that comes up. And what the caregiver will then do is do everything to sort of, handle everything themselves so that person doesn't have to sort of be outed as having this condition. So I think that with those sorts of caregivers, what we notice in our organization is we'll often get a phone call from a caregiver sort of businesslike, wanting information, wanting to know what we do. We'll meet with them, we'll give them our pamphlets and our information, and they are really looking more for tips and strategies. They don't want a support group. They don't necessarily want one-on-one support, but what we find as a trend is give it 3 to 6 months, and that person will call us again, right? Because what happens is that burnout starts to happen. And that's fair enough. With caregiving, it's both a physical, journey through someone's illness, but it's also an emotional journey. It's a process, right? And I think Beth spoke to that so beautifully about saying, at the beginning, you don't really realize you're a caregiver, and that people can point it out to you and you just go, no, I'm not. But it takes some of us a while to recognize that that is what we are, and that if we're going to do this well, we're going to need help. We're going to need help to do this. Everybody needs help to do this.
Well, and I think the important part of it, if I can just jump in, and Jody, I do want to make sure that we don't miss Pasha's question, but and this kind of speaks to what Helen described, but also a bit around what you were speaking to in terms of when you identify these support networks or circle of support. On the flip side, what I would say is the people supporting us often actually do want to support us, and as circle of support, each of us brings different skills, and so sometimes for some of us it's more natural to be able to, say, be a companion, whereas for some other supports, they're uncomfortable, say, with dementia, or they're uncomfortable with certain behaviors, but they're really good at doing research, or they're really good at helping with a task in the home. And sometimes I think it's also really important to recognize that piece, that often it does take a lot of courage, and it does take, I think, a lot of our pride sometimes to ask for help. But once we kind of get over that, to know that people actually do want to support us. And it's just around matching sort of what is required to that person's level of comfort or their skill set. So I just want to bring up that piece. And then the other piece, too, which I think is, was really important around what Helen was speaking to, is there's something, called this personal inventory of resources that all of us have. And whether it's caregiving or whether it's, we experience our own injury or divorce or, whatever that is, whatever transition is that we're going through life, that we know what resources we have internally, but also externally. And I think sometimes those external, maybe who don't have that say, emotional attachment to us, that maybe are sometimes more objective, but they're still in our lay category, can be extremely helpful to us as part of that healthcare team. And I just remember one situation. I'll just quickly bring this up from my own personal experience with my mom when she had bladder cancer, and she was going through all of her surgeries, and we were trying to all sort of care for her post-surgery. We'd kind of forgotten that one of our family friends that lived in sort of 2 or 3 hours away had used to work on a cancer, in the actual field of cancer, and was a nurse, and her name came up one day, and I said, Mom, we should just call her and see if she's ever coming through Toronto, or if she would mind making a trip and just helping out for a week. I mean, I know it's been 2 or 3 years, and sure enough, we called her, and she said, oh my God, I'll be there, I'm retired. And she was down within 2 weeks, and she spent 10 days with my mom, and for our family, it was amazing that she did that for us. And I know that might seem like an extreme situation, but in that, none of us had that experience. And here was someone that could completely reach my mom in her peer group, and my mom was willing to accept that help too, because she was quite embarrassed about her bladder and what that meant, and she didn't want her kids to see her at 65 with these issues. So I think sometimes it's having that ability to also kind of really look at our broad circle of networks. Yeah. So, Jody, one of the questions that I think would be really helpful, and I think this ties into Pasha's question, is, for example, what happens when you get pushback from your physician in the sense that they're not recognizing the situation, or, for example, when you're in a residential care facility and you feel the facility is making decisions about the person's care without consulting you, even though you have the proper designation as a healthcare representative.
Yeah, and I think that's a common situation that comes up, and of course it really taps into our sense of respect and safety. You know, we want to be able, especially when our loved one's in a residential care facility, we want to be able to feel like we have a trust-based relationship with the caregivers there. And it's tough when we feel like they're kind of going around us, or maybe they're not respecting our wishes. It's interesting too when we, you know, if I'm reading Pasha's questions, it's sort of like they're making decisions about the person's care. And, you know, I think in long-term care facilities, they make decisions, hundreds of decisions all day long, and for them, some of these decisions are just kind of routine, and they may not be aware that they're overstepping when they're making those choices. So part of, I think, our role when we get pushback from, say, our doctor, or we feel a sense of not being understood or heard or respected in a formal situation, is to get some advice, which is exactly what Bash is doing right now, is to discuss it with a neutral third party, to get an understanding of the conflict, to really understand, like, what is it that we're expecting, and, you know, not even necessarily whether this expectation is realistic, but more like, how can I get this? I have a need in this situation to be seen and heard, to be respected, and how can I get this need met? And a lot of the time, you know, we do go in there with guns blazing and we're angry, and what I know about communication, and also having been the social worker on the other side of that conversation sometimes, is it doesn't get us what we want. You know, if ultimately what you want in the big picture is to continue to have a respectful, trust-based relationship with the long-term care facility, you can absolutely advocate and disagree and get your point across, but you can do so in a way that does not alienate or create continuing conflict in those relationships. So I think that's something that's really important, that we're not just communicating in this instance about this one thing. We're creating a relationship of communication, and particularly, because, you know, we'd like to have that relationship be in the long term, right? So the first thing I would say is to get some clarity about what is the best outcome that you're looking for in this situation. That would be the first thing. The second thing would be to get really clear about what it is that you want to say, and I'm going to put a little plug in for our next webinar, which is about nonviolent communication, because there's some strategies there that can help you to have conversations that do not escalate, that stay in the realm of respectful communication, and that's by clearly advocating for how you feel, what you need, and then making a request. And so oftentimes, like, if we go in and we say, this is wrong and that's wrong, and, you know, I'm being disrespected, then the people on the other side, even though they're professionals and this is their job, they're going to get defensive, and then our communication is going to get tense. You know, and you know how that goes, right? That you have a difficult conversation, and then the next week, and you see maybe some of those same staff, and you feel uncomfortable. And I think, especially in a long-term care facility, we really don't want to create that kind of situation, even though we might be right. You know, you might be completely 100% right about that situation. So I would say to use some of those strategies for good communication. Sometimes, and you know yourself, everybody knows their own communication style. Like, sometimes if I'm presented with a conflict, I will just cry. You know, I'm a fairly bright person with a master's degree, and, you know, I'm a little articulate, and I will just start to cry, you know, because I just feel I get a little overwhelmed, you know. So it's like, if you know that you're a person who has trouble articulating how you feel in a one-on-one conflict sort of situation, it might be a better idea to write a letter. or it might be a better idea to have somebody come in with you, to be with you and help you to stay calm through that conversation. It's great if you can have like I'm not sure, Pasha, if your residential care facility has, a patient advocate or a social worker or somebody who's sort of a bit off to the side of the people who are providing the care. So sometimes it's great to be able to get somebody else to help you communicate your needs. And I think you also want to assume, which is maybe a little tough for us given our experience sometimes, but sometimes we want to assume that the residential care facility wants to maintain a good relationship with you and wants to respect your care choices. They want to. They're just going to make mistakes. So
I'm just typing my question, but maybe I'll just ask it. The great, that's great tips and great advice, and I hope, Pasha, that helps get you started in the right direction. What I wanted to know, and one of the situations that I often come across with family caregivers, they'll ask is, well, like, who's the best person to start that conversation with? So let's say, for example, it's a change in medication all of a sudden. So you were there one day, and the next day there's been a change in medication, and as a family caregiver, there was no information passed. So for that kind of specific example, who would be the best person to start that conversation with?
Yeah, okay. So I think that, the people that we see often when we go in, we don't often see physicians, right? We most often see nurses. So I think you can start with the people that you are most familiar with. Most of the time, if your person's in a long-term care facility, you know some of the staff, you know some of those people. But a lot of the time, they may not have all the information that we're looking for, and they maybe won't treat our question with the seriousness that we are posing it. So you always have the right to have communication with the physician who has made the medication change, but part of, I think, our reasonable expectation is knowing that you can't necessarily talk to them about that today, right? So sometimes you have to wait to get that question answered. And I think that sometimes may be helpful is when we can go to a social worker or go to the director of care or, somebody who is in the who is more of a between person, that if you feel like it's a pattern where you can't get these questions answered in a timely manner, then that's kind of a big picture feedback to give to the facility, right? So this is where it's also helpful and feeds back into that idea of best strategies. The best strategies is to write things down, right? And so even on, say, Wednesday, October 27th, you asked a question about medication, and this nurse told you this information, but you said you'd still like to talk to the doctor. Now, you can document how long it takes for that request to happen, right? And then if you have a couple of those incidents, it's not like you're an investigative reporter or a lawyer. We're not doing this with, the spirit of spitefulness or anything like that, but we just want to be thorough. We care so much about this person, and, honestly, this is a great thing that we are so invested in the care of our loved ones, right? So if we can approach it with the right spirit, well, then we can say, so I have a concern. I'm a little worried. I feel like, I'm asking questions and it's important to me to get the answers. And, on these 3 occasions, it took 5 days before I was able to get that question answered. So how can I get my need met in a different way? Am I asking the wrong person? You can ask people, who is the best person to ask if this is not the right way to go?
Mm-hmm. That's great. Thank you. So, Pasha and Helen, I hope we were able to answer your questions. If you'd like to write any other follow-up or ask any other questions, please use the chat box. We've certainly, Jody, thank you for that incredibly informative coaching session. It was just fantastic, some of the tips and strategies and being able to help answer some of those specific questions. At this time, we certainly invite questions for Jody and or Beth still. And again, you can raise your hand. You can type them in the chat box. We can go over the tips. Yes, actually we have some slides that are tips. Yeah. So maybe while you're thinking about your questions or thinking about raising your hand, I think some of the really important points that Beth and Jody spoke to, we're certainly keeping track of all the people, part of your care team. We talked about this sort of who's who in the zoo, having, for lack of a better word, your own set of case notes in terms of what was actually asked for, what was said, what was the expected date that it was going to be done. Really, really important. And the other little tip that I'll say is the more specific you can be with information, typically the better. So if it's especially around symptoms, or if you're noticing things, sort of how long those symptoms last for, what makes them worse, what makes them better. That's really how healthcare professionals, in particular physicians, who are there to diagnose and treat. And I think, Beth's point about expecting to navigate across separate programs and agencies that may not know about each other is really important. And I really thought Beth's quote around never confuse frustration with the system as inability to continue caring, really, really powerful statement. And Beth talked about, the sort of self-care is hard but so important. I think what was so interesting was to hear about people kind of identifying and accepting becoming a caregiver, and that Beth talked about sort of developing the systems to streamline her own life and activities and how to manage that triple threat or that triple role. And that I remember also, Beth, that you talked about the really importance of getting lots of rest and that you're non-negotiable with sleep. And I think that was a really important tip. Sometimes it's just one thing. And as you said, some days you don't have all those Dale Carnegie moments, and sometimes you don't get those those sleeps that you want. But striving towards that is really important. So those were just great. This whole idea of sort of a plan for after-hours support, I think that's actually a really, really key one for caregiving. I think about, just anything that could kind of go wrong. But I think it applies, across the spectrum of caregiving, especially, say, for individuals that are doing more palliative work at home. They have the person they're caring for at home, kind of knowing what happens after hours when people aren't available, especially if it might have to do with, sort of medical. And these checklists of yes and no questions for, questions to bring in. Giving yourself permission to ask for help is, that's a big one for family caregivers. And I think, Beth and Jody, both of you talked about this, that just being aware that your physician may not be up to date or aware of utilizing other parts of the system. And I had a really interesting conversation with my family physician, and what I thought was really remarkable on his end is he said, Wendy, I was trained to treat and diagnose. I wasn't trained to do information referral. I wasn't trained to connect all the dots between the systems. He said, so it's taken me 4 or 5 years to change. So just as we need to accept our role as family caregivers and that we're resisting that change, I think sometimes just our healthcare professionals are going through the same thing, that the system's changing on them as much as it's changing for a family caregiver. And that's not, so I think that having that team approach is really important, and being understanding of the other person as well. I think the piece about having a neutral third party is a really great tip, Jody and Beth, about having someone you can bounce your ideas off that's not emotionally connected, or someone that can just bring a different perspective. And Jody, you talked about this, so important. So what can the formal system do for us versus our other needs, and how can those other needs be met and by whom? And then, of course, for you to take advantage of the Caregiver Support resources that the Family Caregivers of British Columbia offers, whether it's a support group, whether it's webinars, whether it's fact sheets, whether it's a one-to-one consult. There is support and resources available. So just looking at our time as well. So if anybody, I want to thank both Beth and Jody so much for their time. Yay. And I think I'm really pleased. I think
you know, it's been a great exchange, and yeah, just really